course, Dr. Patino, 30 plus years of experience in psychiatry and in medicine. And we're going to talk today about something that I think affects all of us. It's universal. And lately, with COVID and even some of the stuff that's happened in our society, there's been a lot of loss. And in particular, where people's response to loss is the grieving process. Um, I think we should discuss that a bit. What do you think today?
Well, I mean, I find that fascinating. I think that that's something that my specialty deals with. The cases are very complicated, but I think it's important to understand the topic. I think it's important to understand that loss is universal, right? It's part of humanity, and has been somewhat controversial in the psychological realm in terms of how we look at it and in terms of how we deal with it, right? I mean, you can go back to the Freudian times, and Freud has his own theories about loss, and then we have Kubler-Ross later on with her stuff about loss, and then most recently we have Dr. Banana from Colombia who has done really interesting research on the whole grieving process and in particular concept that he developed called resilience. But I think it's important to understand context, right? Because we usually think of grieving when we lose people, but we can grieve a lot of losses, right? I mean, loss is painful for people in general, not catastrophic, right? And contextually, we have to decide, okay, so what kind of a loss you had, right? You had a loss of an idea, you had a loss of a concept, you had a loss of an expectation, you've had a loss of hope, you've had a loss of a person, right? So what you've lost is going to have some impact on what kind of grieving you're going to do, right? With the understanding that grieving is a normal process. And for most people, we're talking about probably 85% of people, it's a normal self resolving type of situation, right? So we have that context in place right now. A lot of things that have happened over the last year and 3 months have complicated grieving quite a bit. I mean, so COVID-19 has been problematic, if you may, because it has kind of interfered with the normal processing of grief, right? Because culturally we have ways of processing our losses, right? So right now you don't have a lot of funerals, you don't have a lot of people going to the funeral home, you don't have a lot of people going to church. So whatever coping we have learned and we have kind of learned through culture and experience has not been available. That is one idea.
Yeah, it seems that a lot of structure and, like you said, ritual even that we used to cope with that has been taken away. I also know quite a few people. I've lost quite a few friends. Actually, had 6 friends that I know to COVID, and quite a few of them, 2 of them, their elderly parents passed on, and they were not allowed to be with them. It was a very difficult time, something that was removed from them, and the grieving process actually almost started earlier. The minute they entered into the hospital or hospice and was separated from the family, it was almost as if they were written off. It sounds kind of crazy, but that's kind of what happened. And when they knew they were going down that hill, not being able to be with them, I think caused them more pain than the loss itself.
Well, I mean, I think that COVID made our ability to grieve more complicated, but it also made the experience a lot lonelier, right? Because people didn't have the ability to have communal grieving, right? And communal support. So whenever we confront the situation of grieving, we have to start with understanding that the person who's suffering because of grieving, okay, is not a problem, right? We don't need to perceive that person as you're a problem to me because you're suffering and I don't know what to do about it. Because the reality is that the person who is trying to help can't do it very much, right? Except to hold hands and say, I'm here. How do you want me to help? I understand you lost. But be careful of not saying those things if you don't believe that, right? I mean, we have some cultural issues in terms of what is the appropriate thing to say, what is the appropriate thing to do when you're confronted with another human being who's grieving, right? And we have expectations of ourselves. But I think it's important to feel empathy, right? To understand that if you put yourself in that individual's shoes, you may feel something, and you need to be aware of what is that something that you would feel. So you can honestly say, I understand your pain, right? Sometimes we understand the pain because we have suffered that before, right? But during the COVID process, there was not opportunity to do a lot of that. And I have to tell you, um, during COVID, we also were confronted with people losing contact, right? And I can't tell you how many times doing the Zoom thing, with my patients, I hear, you know, I miss simple things. I'm grieving the loss of a handshake. I'm grieving the loss of not being able to hug my grandchildren. I'm grieving the loss of not being able to take a walk, and exercise. Um, and on the other hand, you have the people who want to be with their grandparents and older people who are not able to do it because they're concerned they may hurt them, right? So that sense of closeness and trust was there, right? I mean, you would have to make decisions as a child, right? As an adult child, of putting a relative in the hospital, not knowing if they're going to come out of there and understanding that this is probably the last time you're going to see them. That's a pretty scary thought, right? So from that perspective, we need to be able to listen more and talk less, right? And we talked about that before. We have to hear people suffering. In our society, suffering has become a bad thing, right? It's not something that you should have. That is in one hand. On the other hand, when it comes to grieving and loss, in particular loss because of death, right? Most kids, um, only under the age of 35, haven't lost anybody ever. They have no practice on grieving anybody,
That's true.
right? So in the old days, people would lose people very often because of illness, because of delivery that went wrong, because there were a lot of kids being born, because we didn't have the same amount of quality medicine at the time, and we live in the bubble of the first world, right? So we always tend to see loss from our perspective, right? From our point of view as a first world society. But what if I tell you that in countries like Honduras, El Salvador, Guatemala, southeastern Mexico, I don't know, 15 to 20% of children die before the age of 1 because of diarrhea, right? So loss is part of daily life, right?
Well, they're living like we did, 50, 100 years ago, like you said, before truly pre-World War II, really, or even during that time, Depression era. Um, you mentioned that a lot of us don't have practice, and you're right. When I met my wife, she had her first father-in-law pass. Other than that, she had no experience with death, and I had a slew of passings with some friends during that time. We went to multiple funerals, and she even mentioned, she's like, "Wow, this is a really bizarre experience because you're right. Most of us don't have death unless you've been to war or you've lived in a poor area or had some just offhanded thing. Most of us live pretty healthy, long lives. And that experience of learning how to grieve and learning how to manage is really put off till much later in life.
Well, let me tell you something. And I mean, I'm a product of the '60s and '70s. You know, uh, that's where my youth happened, and mostly the '70s. And something happened in the '70s that I think was pretty unique. Um, and I'm not somebody who's in favor of military stuff. You know that we know each other, and I'm not big into military and exercising power and things like that. However, something happened to the values in this country when we stopped the draft.
Hmm.
Something very different, right? Because yeah, nobody wanted to be drafted, nobody wanted to go to war, nobody wanted to do those things, and I support that, but it wasn't replaced with anything. I think that the draft should have been replaced by I don't know, community service. At least a year or 2 years. I mean, something that would give people understanding of the differences, with the people that you don't know. Because whether you like it or not, okay, whether you were into white supremacy or Black Lives Matters or whatever it is back in the day, right? You had to be forced to look at people who were different than you. You had to be exposed, okay, to different cultures, to different colors, to different ways of thinking, right? And I think that that was a huge equalizer that we lost, right? And we never grieved it.
Hmm.
If that makes any sense, right?
We actually celebrated it.
Yeah, we celebrated the end of the draft. And I have to tell you, I benefited from that. I was probably 16 years old when the draft ended, and I was a dual national, Mexico, United States. And I had to make a decision at age 18 in terms of registering for the draft or renouncing to my US citizenship, right? I didn't have to make that decision because they became the selective service and I registered when I was 18 and that was it. I don't know what selective service was for, except that they had your name, right? So I was never asked for anything. So and I'm not talking about, oh, we have to give something of ourselves to our country. I don't necessarily believe in that, but I do believe in building character, okay, through experience. And I think that we have deprived a few generations since then, okay, of the opportunity to build character, including dealing with loss. Okay.
Well,
Um,
I think there's some certain areas of our society, obviously people in the military have been at now some form of warfare for almost 20 plus years. My friend Dan, his mother passed. I mentioned it before the show, and she had delayed treatment for the last part of her life, where she was in a significant amount of pain because of advanced and very aggressive bladder cancer, because she had tested positive for COVID. She was left in the COVID treatment, and until she tested positive, they would not treat her for the thing that ultimately killed her, and that was
mm,
very difficult for him and his family. Fortunately, they got her into treatment toward the end. It was mainly pain management, and because of some connections with the hospital, he was allowed. The entire family was allowed to be near her during her passing. But still, somebody like him, he has spent 20 years in the U.S. military, has seen loss, has seen some sacrifice, has been exposed to other cultures. Myself, I've been very fortunate. Got to live in a couple different countries, and I've traveled to 17. My father's not from this country. I've been to his country, and it's not the most developed place on the planet. And I got to see those things. And I think you're right, that diversity, the understanding that life, the value of life, it's not to be taken for granted, and that in other places, unfortunately, it's cheap. It's it's accepted as fleeting, as opposed to here in the first world. It seems to be all about extending it and enjoying it to its fullest.
correct. But well, it goes beyond that. um, and I call it the entitlement to not suffering,
Mm.
right? That I'm entitled to not have any emotional pain, and I will make somebody responsible if I do, right? And that creates a whole kinds all kinds of complications. So I think that we get back to the issue of grieving. The most important aspect is to understand the normalcy of it, right? But we also need to recognize that the intensity is different. You know, if you lose a parent when your parent is in their 80s or 90s, right? Than to lose a child, especially a younger child, right? And in my experience, I would say that, and I've never lost a child, but um, I've seen people who've lost their children, and it's probably the most catastrophic and painful experience, you know, for a human being, both mother and father. Okay? It is something that goes beyond our understanding because that bond between father and child and mother and child is extremely powerful, right? And it's not just psychological, it's not is a biological, connection that it really feels like, and that's been described to me as somebody put a hand in your heart and pull it out, you know and it takes a very long time to recover from that. The other part that we need to understand is that in over the years we have heard a lot about um, the stages of grieving, right? That you have to follow these four stages.
That's Kubler-Ross work for the most part, correct?
Correct.
I took a graduate level class in college. Actually, I had to take Psych 101 concurrently because I hadn't taken any psychology. Of course, I got a C in Psych 101 and an A in the graduate level course, but
Well,
because it was much more interesting.
you're getting a master review now, so
Absolutely.
just kidding. No, what happens is that I don't think that um, the stages of grief are necessarily wrong. I think that what is kind of very individual is how it happens, right? So it doesn't have to follow the sequence of specific stages. It can happen one first and the other one second, right? And that's very individual, that's very cultural too. But if you want to understand grieving, you really need to think of waves. It's more like the sea. It comes and goes, right? So when and normally in resilient people, the waves become less frequent and less intense. And I like to describe it sometimes as, and I think I've told you this before, like somebody takes a chunk of uh, part of your arm, right? And just pulls it out, and you have a big hole in your arm, and it's bleeding, and it hurts a lot. That's when you sustain the loss, right? And then you get into a wave of calmness, and you get a little bit of healing. Then something happens, and the scab gets removed, right? And when the scab gets removed, it starts bleeding again, and it hurts a lot. But the size of the injury is smaller, it's concentric. So, what you hope for when you are grieving is to be able to get to a point in which you can look at the scar and it reminds you of your loss, but it doesn't hurt anymore.
It's interesting you said that. I have been accused of being very distant when people pass. Um, however, a year later, I'm all over it because that's when everyone first has forgotten. That's when that seems to be that first scab removal occurs, when the first anniversary comes up, the first Christmas, all these like and the like. I've always been that person to be there for my friends at that time when everybody else forgets. And then I've watched them over a couple of years. My other friend Tim had a very horrible experience. His significant other died a couple years ago, and watching him go through that, same thing. Everybody was there, when it first happened to support him. I made sure that next year, Julie and I, my wife, made sure that he had someplace to go for Christmas, all that the year after, and during all those other times. And then over the last couple of years, watching him get to that point, where every year it was the scab or looking at the scar and feeling just the pain, and
Mhm.
they got to the point where it healed enough where it was, you know what? I'm thinking more of the joys I had with that person. Yes, the pain's still there. And the focus of the memories changed from the pain of the loss to the shared experiences they had in their history.
And I think it's very important to allow people to live their grieving and their loss their own way. Something that we have traditionally done that it could be damaging to some people is to force them to talk about their loss, right? Is when we start saying, uh, tell me about the bad memories, tell me about the pain, how does it feel? Sometimes that works against the resilience of the individual, right? And every individual has their own experience, their own way of coping with this. Now, we're talking about the 85% who will live their grieving in a healthy way, right? And they're probably going to live their grieving in a healthy way by themselves and with support of their friends and family, and nothing is going to happen. Problem is the other 15%, right? When you find an individual who lost his wife and ended up in the hospital because of suicide attempt. The pain was so big that they felt their life wasn't worth living without the significant other, for example, and then we have to intervene, right? In those cases, the approaches are a little different because um, you have a non-resilient individual.
Mhm.
In other cases, you have people who are very sensitive to trauma, right? Or that the loss awakens trauma that has been more dormant, right? So we have to be careful on having a good assessment of these individuals and allow the individual to take responsibility for staying alive, but at the same time guide us into the how to, right? Um, and Dr. Bonanno from Colombia really has interesting work, not only in terms of grieving, but on child abuse, you know, in terms of is it healthy to try to do therapy with these individuals who have sustained severe trauma or child abuse? Are we actually helping very much by doing therapy or not, right? And he raises very interesting questions, not based just on his beliefs. He's done research on it, right? So if anybody's interested, I would really encourage him to look into Dr. Bonanno's work out of Columbia University in New York. I mean, I think his work is really fascinating because it teaches us when not to intervene, right? That us professionals getting into wanting to fix everybody outside of a theory may not necessarily be in the best interest of the patient. And sometimes the best thing that we can do is to let the patient know that we're there, we're available, we can be a holding hand, but let the patient guide you.
So instead of hearing the typical, prototypical question, tell me about your childhood,
Yeah,
we might want to ask, tell me about your life now.
correct.
Tell me about how you're being affected. I actually remember you saying that to me at one point. You said, "Is it really important to look back, or is it important to move forward?" And I agree with your assessment. I think it was, and I think for a lot of people, you're right. Digging up that trauma again is picking at a scab when we should probably just let it be healing.
And you need to understand that sometimes we awaken things that the patient is not aware of, right? And you always have to ask yourself, and this stuff that we're talking about right now, Vince, really is controversial in the trauma environment because in trauma therapy there's always this drive, to uncover and process and overcome the trauma, right? sometimes we don't want to do that, right? And there are a lot of biological and psychological reasons, right? That there's not a mold, right? That you say trauma, you have to do this. And we're seeing a lot of that happening now in terms of people really wanting to fix. And my code word is not fix, is understand.
Mm,
I think that understanding and giving the patients understanding back in terms of their life today facilitates their functioning a lot more, you know, than spending months and years trying to explore things. That's why I moved away from Freudian psychoanalytic theory, and is that I don't disagree with the concepts completely. I don't think they're very useful
mm,
in terms of helping the individual. I think it's very useful in understanding the individual. Those are different things. I think we fell into the um, fallacy that knowing the individual circumstances gives the patients more options, right? And that is very individual. So I probably move more into the self psychology area, which is still somewhat analytical, but I think that that helped me understand people better because I want to understand so I can give them better options, not because I want to fix anybody. And you see, the whole concept of fixing trauma has an implication that the patient is broken.
mm.
And the whole idea that the patient is broken, I think, is problematic. And it's problematic because it forces people to see themselves as being broken. And even when people are grieving and people are going through very difficult times, I think I need to remind them, you're a normal person who's suffering a lot. You're not a suffering person. And you and I are kind of working on this concept of the bubble of misery and the ins and outs and the how to's and all of that. But I think that when people start perceiving themselves as being defective, their options are very limited. Actually, it's limited to being somebody else that is not broken, right?
Yeah, it's a lot of self-labeling. Instead of being a person that has diabetes, you're a diabetic, or a person
Correct.
who suffers from bipolar, you are bipolar. It becomes an image, or someone who suffered a loss, you're a grieving person.
Mhm.
Um, that can be difficult. You're right. People self-label, and as you mentioned before, it's like handling not just the bubble of misery; it's that ball that has a label on it. People will hold on to that because it's what they know. So the grieving widow will continue to be the grieving widow instead of moving on with her life, or the person that has been, had a trauma in childhood would become that. I know some of the folks I deal with in the military, watching them get past some of their trauma, or even the experience of going from special guy to normal guy overnight, is something that they really have to be okay with letting go instead of actually holding on to it. And with the
Well,
grieving process, it seems that that's part of it too. We sometimes enjoy holding on to that pain.
well, there are some masochistic people out there, but there are also some disturbed people who perceive their loss as an opportunity to manipulate, right? So we do see some of that. We do see people who become addicted to having people feel sorry for them. Not a lot. That's not a high percentage of the population, but when you're still getting into the 50% that agree pathologically, there are a lot of different versions of that, right? It's not just one. Um, and then you have people who are not capable of understanding grief, whether it's by biological reasons or whether it's for um, personality issues. You know, it's like somebody who's highly narcissistic cannot be empathic to somebody else's suffering. And the, the pain only matters if it's happening to them,
Mm,
not if it's happening to somebody else, right? Well, the antisocial who can only perceive the gain that they can get, you know, from other people's suffering. It doesn't mean that they don't suffer, right? but it's very short lived and it's always about me. It's
Mhm.
not what happened to the person, right? Whether it's a psychological or a dead loss, it's always about themselves. Those are the self centered type of personalities. And then you have people that tend to act out quite intensely because they may perceive the loss as a rejection of them, right? Like, you never loved me and now you leave me. So I'll
Mhm.
never find out, right? I mean, those kinds of situations you get into other type of intense personalities. And one day we'll have a program about my concept of personality disorders, which I don't think they're really disorders, but that's what they're labeled as. So I think that we need to have a bigger perspective on the individual we're trying to understand by looking at the movie of their life. So that's where I find fascinating the past, not necessarily because I want to uncover the bad stuff, but what I want to understand, how did you get from point A to point B, right? Why are you in my office today?
It's context.
Context in terms of the movie. I mean, and I like movies and I love movies. And I think that we psychiatrists are really screenwriters, right? That's what we do. We write the screenwriting of every individual's movie, and we want to understand it, right? So the next chapter after they come to see us becomes less painful or more adaptive or more functional. But I can only help them with that if I can help them see their movie, you know, and where their understanding of the movie, okay, didn't happen the right way. Not in terms of what happened back then. Yeah, it was very painful that your dad never liked you. What did that do to your life and where are you now?
Mm.
And instead of saying, let's try to relieve the trauma of your dad not liking you, or relieve the trauma that your dad was physically abusive, or or relieve the trauma that you were abused sexually when you being told that you were sexually abused when you were 3 years old, right? Um, do I really want to uncover that or see if I can get any recollection from the kid? No, that's what he's been told, right? So how did that impact your life going forward? So that becomes important because I always have to remind people that there's a point, especially with people having traumatized, that you need to stop being your own victim and start being a survivor. When you start moving from being a victim to being a survivor, you start looking for options, right? So how do I go about being a survivor? Because being a victim becomes the bubble, becomes what you know. It's not comfortable, it's painful, but that's all you know, right? And the earlier we recognize that for kids, and the kids get very surprised when we tactfully tell them, you survived it. Yeah, it was very painful. You were raped, you were physically abused, you were abandoned, but you survived it. How did you survive? How did you manage to survive your loss, right? Resilience again. We have to help them see their own resilience. We have to help them understand as much as it hurts, you move forward. Yeah, dysfunctionally, yeah, in a defined way, yeah, depressed, yes, anxious. Yeah, we can take care of the symptoms if we need to. But you did it. You're sitting in front of me talking about all of these things. You. Hence the only you, right? I mean, that's where the concept comes from. That each individual has to learn to be responsible for how we deal with both staying alive and moving forward. And instead of pointing the finger, right, which is, I see a lot of teenagers, that's what teenagers do. You make me feel this, right? No, I don't make you feel anything. You feel what you feel, okay? and you may not like what I do. So what are you going to do about it? How are you going to take what you know to make your life better instead of focusing on me? Because if you're focusing on me, what you're saying is, you make me this and you can fix it. Right? Usually they'll tell you can fix it by stop doing what you're doing, right? Stop being my parent. Don't set any rules for me. Those kinds of things. And I think that there is some degree of loss and grief that's attached to just being an adolescent, right?
Mm.
I don't think that we recognize it as that, because adolescence by itself is a process that includes loss and change and new, right? That kind of mimics, the whole grieving process, if you
I'll
really
say,
think about it.
I'll say, yeah, a loss as an adult, like a death, is almost like a post-adolescent experience. I mean, obviously, it
Yes.
is chronologically, but there's an analogy. It's analogous a bit to that, where your life is fundamentally changing, and then you have to adapt to it.
Something that I find terribly problematic is to deal with the grief associated by somebody close to you dying by suicide. That is a very particular, difficult situation to deal with,
I've known
because
6 people have taken their own lives.
yes, and it's kind of logically senseless, and it's sometimes, especially if you're very close to the person, you start wondering, was she doing it to me?
I had an experience with a friend who took his own life, and the week before bought a casket and had me help him move it,
Mm.
and that was rough. I had no clue. He said it was for something else, but it turns out it was part of his planning, and I was part of that. I had to ask his widow and his parents, in a way, for forgiveness. I was feeling pretty bad about it, but in the end, talk about empathetic or empathy. They all looked at me and said, "You couldn't possibly know,
Well, no,
possibly know."
the issue of suicide is one of those grieving processes that come accompanied by a lot of guilt, in terms of what did I do wrong, especially if it's a child, or only if I've done this, only I've done that, right? Uh, I have to tell you, because I've been dealing with suicide for 33 years, and I did a lot of emergency psychiatry. And something we've learned in psychiatry is that we're not very good at predicting anything, right? We professionals, we're trained to do this. The prediction of suicide is not possible. I think that's an accepted fact. What we look for in suicide is risk management, meaning, can I identify certain parameters that tell me that somebody's at risk? How high of a risk? And what is the process that we need to embark to reduce that risk, right? So when we talk to parents, um, when we talk to families, we're always talking in terms of, these are the signs and symptoms that things are getting worse and we need to intervene. These are the resources available. But from that to say that we should be able to keep somebody from killing themselves, I don't think it's possible, right? I think that we can recognize the risk and take measures to prevent it. And as I tell my students, um, I don't see a lot of the people who complete suicide because they're dead. I tend to see the ones who did not, either by accident they stay alive, or they were giving a lot of signals that they were in distress, as an attempt to not end their lives, right? We take them equally seriously, right? But there are very few cases in the last um, 33 or 34 years in which I saw a patient who put a gun to his head and pulled the trigger, right? There's probably been two of those who survived, right? Or somebody who walked into the desert, without water, and spent 3 days, and then eventually they found him dead. I mean, there are people who are so determined that they're going to kill themselves that it makes me question. I'm not a big fan of the concept of suicide prevention.
Hmm.
I'm a very strong advocate for the concept of suicide management, management of risk, right? Because I mean, statistically, if you look at the United States as a country and you look at the incidence and prevalence of suicide for the last, since we've been keeping statistics, it hasn't gone down very much.
Hmm.
So we spend a lot of money on prevention, but I don't think we should call it prevention. We should call it management because we're not preventing suicides, right? And it gives us some false sense of safety, I think, because we have suicide prevention systems. And I think that suicide management systems more than anything else.
Yeah, I think some of the people that experience it, like even my experience, or I mentioned my friend earlier, Tim, whose significant other actually died of alcohol toxicity, uh, drank herself to death. Uh, People feeling very guilty. I know he did, and I think he still does, about not seeing those signs and being there for her. But in the end, as I said, I've had 6 people I know in their own lives. It's their decision. There's nothing you could have done about it other than to see those risks and maybe help manage it. But especially the ones who quite literally shoot themselves, no one's pulling that trigger but them. People who die inadvertently or do overdoses, that's a little bit harder to deal with because maybe someone could have potentially helped stop that. Or do you think at that point, once somebody is at a certain level, there's nothing you can do no matter what?
Well, I think that to, we have to make a, we have to do a better job of educating the public about the red flags of suicidal behavior, right? I think that we have to do a lot more educating in the schools so we can recognize and not overreact. Uh, and we utilize the systems in place, right? The way things are now, if especially if you're a child or an adolescent and you mentioned the word suicide in an emergency room, you're going to go to a psychiatric hospital. And I have to tell you, half of those kids don't need to be in a psychiatric hospital.
Mm.
But nobody's wanting to spend the time to look at how do we manage this risk? Because them being in a psychiatric hospital for a week or 10 days or 30 days is not going to change their circumstances at home. It's not going to improve their relationship with their parents. None of that is going to change, right? So we have to do a better job of being willing to manage the risk associated with suicide and with homicide, in a more adaptive way. I mean, I for every 10 suicidal patients I admit to the hospital, I probably admit one or two for homicide. I want to kill somebody else, right? So, um, yes, we identify the root causes of it. We start developing treatment plans. We work with therapists on the outside. But none of that is going to prevent that from happening except the continuous working, of doing this. And that could be done from the emergency room, but I don't think that emergency rooms are willing to take those risks nowadays. The other thing that is important to understand is that um, we have to recognize those who are grieving or who are feeling suicidal and do have a mental illness, right? Somebody who has schizophrenia, bipolar disorder, somebody who has major depression, generalized anxiety. There are much greater risk of having complications from this than the other 85%. So those are the people that we usually work with. So I think that there's a lot to be said and a lot to be understood about this, and we're always learning more about it. Uh, but it's one patient at a time, right? It's like the war on drugs. There's just a lot of political slogan to that. The war on drugs is one addict at a time,
Mm.
one person who's addicted to drugs at a time.
And
Yeah.
same with the grieving process. It's every individual. But if you find yourself, or maybe you know that you're in that 15% risk factor, what steps should somebody do if somebody who has bipolar disorder loses somebody very close to them, or a beloved pet, or whatever it is, to push them to that area of what would you recommend for something like that to do versus just the normal 85% who go through the process?
Is to not lose contact with people. Okay. And let them know that you're hurting, right? So, who are you staying in contact with? Your family, your friends, your therapist, your psychiatrist. Okay. It's not your job as a patient who suffers from a mood disorder or a thought disorder or a trauma anxiety disorder. It's not your job to make the doctor, the therapist, or your family proud of you because you're handling things very well. It's actually your job to let them know when you're not doing well, right? So they will be able to give you some guidance into the how to. How do we go about this? That becomes important because otherwise you end up um, kind of like giving them a false sense of security, right? And of course, everybody needs to be alert and knowledgeable about their sense of the compensation. If you have bipolar disorder, you're gone without sleep for 3 nights, that could be a problem, right? Or if you're isolating and not wanting to go to work and you're not motivated, that could be a problem. You're very anxious and you're afraid of leaving the house and you don't want to socialize with anybody. Well, to some degree, it's understandable, but how long and how often, how intense it is. So we have to know ourselves. We are the best monitor we have is ourselves, right? When we start becoming dependent on the other people, taking care of us, then we lose the will. And in this business, we always look at two parameters. And I was talking to a patient earlier about this, which is what is your will and what is your ability?
Hmm.
And we always have to balance our will and our ability, right? Sometimes we're willing, but we're not able, right? Sometimes we're able, but we're not willing. And most of the time, we're somewhere in between. Okay. So that's for
So,
another topic.
but it sounds like it'd be important for anybody, whether they're in the 15% or the 85%, to be open to being a little bit, I guess, take some risks to show that they're paying, to ask for help, to keep connected, and to understand. And for us who are on the other side, being there for them, to understand, to allow them their own personalized grieving process, and to process the loss, and to be there for however they want us to be there versus the other way around. We want to soothe them in our way versus, hey, you know what, just let me know what you need. If we do that, I think we could probably help each other get through this, whether you're in the 15 or 85%.
It's very interesting because I think that you said something that is really true. Um, from the non-grieving person perspective, it's a pretty awkward situation.
Very.
You know, what do I do? What do I say? You know, and the most appropriate thing to say is, I hear you. I'm here. How do you want me to help? And I keep going back to that, right? Let the grieving person guide you and trust them, right? Because I mean, you don't want to go and hug them if they don't want to be hugged. You don't want to hold their hands if they don't want their hands held. Okay. If they want to be alone with their crying, let them be alone. You don't have to go and give them the back and say, oh, you know, don't cry. No, trust them. Trust that 85% of people are resilient to manage their grieving.
And just be there to support them.
Exactly.
And those 15% who need help, maybe help them find some help and some support in the way they need best.
And a support that is culturally appropriate to them, not just culturally appropriate to you. So we have to keep that in mind.
Again, back to
Well,
that experience and cultural sensitivity, that's so important for personal development.
yeah, that's a whole big area that I think we need to pay more attention to. We're almost at the end. I want to thank everybody who has been listening to our podcast. Uh, and I was looking at the numbers this morning, and we're about couple of thousand views to hit 1 million views in the last year,
Yeah.
which I think is something that is remarkable for the time that we've been doing this. And we're going to keep doing it. We're going to expand it, and we're going to be listening to all of your comments and your questions and your suggestions. And I think that there's some very interesting things coming down the pipeline. Hopefully, we'll be doing a program fairly soon about alternative treatments for mood disorders like ketamine and psilocybin and those kinds of things. I think that that's going to be a fascinating topic for a multitude of programs, not only one.
And I'm working on doing my best to get some very interesting guests on as well, who can share some of their experiences, whether with autism, uh, transgender issues, and some other things.
Thank you, Vince. Really appreciate it.
Always a pleasure, sir.
Okay, we're done.
Sorry, that was a horrible intro. Just I guess because I'm sick, I'm not feeling
No,
great.
it's fine. I think it was a